Good morning, everyone. Respected Dr. Meena, our friend of the institution, Dr. Mohan, Dr. Selva Vinayagam, and a lot of other senior colleagues and friends that I know. And we are new to Chennai. We have been here only for the past 2 years with the hospital recently. This workshop is all about, as Dr. Mohan pointed out, viable, affordable, and sustainable. Now, I was just saying in a lighter note, we said the time has come to hospitals to become healthy. Instead of hospitals trying to keep someone else healthy, we are in, looks like we are in illness. We have trouble living well, so we need to be healthy in this course. So I'll try to cover this presentation probably in 15 minutes. So this is blindness worldwide, as was pointed out. I think every problem in India is exponential. You take a cardiac problem, diabetes, eye problem, we're talking in millions. Many of these numbers are equal to a population of a small country. In a country like India, which is a younger country, it's estimated that 30% of the population needs eye care. If you go to Germany or UK, you may probably 50% of the population would need eye care because our average age is only about 26 years and our life expectancy is 67. So it kind of keeps your population at that end, the older age, a little tapered. So these are the different physical locations of Aravind. We are primarily in Tamil Nadu. Now we have a hospital in Tirupati and Pondicherry. We partner with other players, but primarily focused in the southern part of the country. So this is us in 2018. So I'll be giving a little overview about Aravind. So that's about 4-5 slides, just to set the context on where we are. We handled about 4.5 million outpatients and performed a little more than 500,000 surgeries. We are a charitable organization. We are a trust. So we have a cross-subsidizing model. 50% of our patients are paying patients and 50% are free. And that's changing with insurance and PMJ schemes, CM scheme. Earlier, where you needed to do charity, now the government has taken the responsibility for those people and the government is willing to pay for their care. So we started with 11 beds. The story is very similar to Dr. Mohan's story. I think any large organization built with the missionary zeal is built that way. Somebody starts with nothing and has a tremendous passion and vision, and then they grow in their lifetime, and the organization continues even after their lifetime if the structure is well in place. So these are different levels of organizations that we have, the large ones, tertiary, primary, secondary, and primary. So on average day, we examine about 15,000 patients in all of our hospitals put together, perform about 1,800 surgeries, and we also are a postgraduate training center. So cumulatively, we've handled about 60.8 million patients. So we have, in every hospital, we'll have a paying hospital, we'll have a free hospital. Patient can choose where to go and get their care. So what's different about Aravind? You know, that's the question. Why are we talking about Aravind in this context of building a healthy hospital? Is our donation or grants that we receive is less than 2% of our revenue. So all our revenue is generated from patient care. So all that we do, we don't borrow as an organization. That's the principle of the founding members. So he said, you never borrow. You have to wait for you to accrue a certain amount of money and then expand. So that kind of became the DNA of the organization. And this is one comparison between UK and Aravind. United Kingdom, which is Britain, does about close to 450,000 eye surgeries. Last year, Aravind did, this is only cataract, Aravind did about 320,000 eye surgeries. And the cost of UK is about 1.6 billion pounds, and the cost for Aravind is about, maybe now it's about 20 million pounds. So there is a significant cost differential that comes. In US, the cost reimbursement for a cataract surgery is 3,450. I think PMJ have become smarter. They have removed cataract out of the list. No, sir? Cataract is still there? But in some states, they have removed. Yeah, in Tamil Nadu, it is not part of PMJ. But PMJ need not get into cataract. That's one of our recommendations, because there is a government program, National Prevention Control Program, which already takes care of cataract in a significant way. Why reinvent the wheel in 2-3 places? So that was a thought process as far as cataract goes. So the cost is about $88. And also the next point, the next aspect that comes is when we all talk about quantity, quality is a very important point. I think Dr. Meena made that observation. I think India is moving towards that direction. You know, a lot of us are talking about as providers, we never spoke so much about quality 10, 15 years ago. That was not the mainstream speak that we had in meetings and we had in our own discussions. Today, I think quality is spoken more than clinical service delivery. You know, you have quality organizations, CAHO is there, NABH is there, quite a few organizations which are there, primarily focused on quality, and which is a hallmark of any good organization that is in the field. So that's about blindness, and that's about Aravind. I'll park them there. What makes an organization build a frugal approach? You know, that's the question that we are all trying to debate. You know, the challenge is, I think Dr. Mohan touched upon it. If you start at a higher level, it's very difficult to come down the value chain. A professor of mine, was Professor Prahalad. He passed away. So he used to make an observation. This was in 98, 99. I was doing my MBA with him. He said, at those times, the companies like Infosys, Wipro, Satyam were all looked at by the international companies as doing cheap labor, because we were all doing Y2K work. You remember Y2K at that point of time, the calendar moving to 2000 and all. So he said, you know, his observation was, don't worry where you enter, because in a value chain, here is the sweatshop work, here is IBM and Microsoft. If you enter the value chain, you always have a possibility to go one way to the right. But it's very difficult for these guys to come to the sweatshop work. So I think that's what has happened in healthcare. Organizations which have started with the DNA of affordability and frugality are reasonably managing the situation. But organizations which have started at the top of the pool, like a more expensive, more five-star, for want of a word, provider of healthcare, they struggle to scale down, because today the price is not in your control. That's another change that has happened with insurance coming in. With all these programs that are coming in, hospitals have very limited power to price our products. Even Aravind Hospital, Chennai, we realize 55% of all our patients have insurance here. So where do we price? The price is already given. You work on that price and you save. If you can save, all you can work on is your cost structure. So he's our founder, founded it at the age of 58 after he retired. So his vision was, how do I provide eye care to all? This was founded in 1976. India in 1976 is very different from India in 2019. You're talking about $150 per capita income. Real poverty. Today you don't see that real poverty in Tamil Nadu like states. There is no abject poverty in Tamil Nadu. People are reasonably well. People can have 3 meals. I was taken when I was first time when I went to US. They took us to a charitable project. I said, I'll go to a charitable project. I wanted to see what it was. So they said, we are going to help a family build something. They were building a room or something. And I go to that house. They had television, they had a microwave oven, they had a car in front of them. And that was a family which needed support. And India is kind of it should move into that direction. You know, you should not have people struggling. And we see that. All of us see that, everybody has a good mobile phone. Things are changing dramatically with time. Aravind now covers a population of 100 million people, and which is Tamil Nadu is about 72 million people, neighboring parts of Andhra and Kerala. For this 100 million people, Aravind provides 45% of all eye care. So say every second cataract surgery or every second surgery done in Tamil Nadu is done in one of the Aravind hospitals. So that's the kind of penetration that this organization has in the population base it covers. So what are the key elements of a leader or a founder who in our case, it was our founder. What did he have as some of those key tenets that made this possible when we look back? I think he owned the community's problem. I think we today own the hospital, but not the community's problem. We always think from our context of 100 beds, 200 beds, 300 beds, this equipment, that equipment, but what does the community need? And at what price point does the community can afford that need? So those two are seldom discussed before we establish an organization. And in our case, we had a luxury of 40 years. I think it's important. It's important to take, because those formative years are very important to build the DNA, which needs to be very strong. And he was also very far-sighted. I think a lot of our hospitals, a lot of our healthcare centers which come are not very far-sighted for the, sorry, I think I touched something. Yeah, far-sighted because the financial pressure on them. They've already borrowed money. They have already recruited doctors at a very high salary. Where do you have far-sightedness? The bank will knock at your doors the next month. The doctors need to be paid salary, your staff need to be paid salary, but your patient volume will come 2-3 years down the line. So the first 3-4 years, you don't know whether you have taken the right decision or not. So somewhere starting small, I think 25 beds, I think Dr. Mohan made that observation of why start big. And also some sacrifice. Today in many a times in healthcare organizations, we are not talking about sacrifice. That's not an element discussed. We want to go into one plane and then start from there. But that plane may not be adequate because you don't have the roots to be able to hold on when you are in difficult times like us, like where we are today. And he also led by example. I think Dr. Mohan is a similar person. People like him are leaders by themselves. So they are role models for their team and also for the larger people who are observing them. The simpler lifestyle, people are watching us. In a healthcare provider, that's a challenge. We are in public domain. Who we are becomes more important. What we wear, what we drive, where we live, all of that is watched by people. The society is very open now. So we can't say something and do something else. So one has to both speak the language and also live by what we say. So these are the building blocks of Aravind. A lot of times, as was pointed out, the infrastructure is given too much importance, not the value system based on which you build the organization. The value system today is very driven by economics and the finances, not by the purpose for which you have become a physician, and also what your organization has to do. As a healthcare provider, we can take a lot of pride. People in the community need us. It is not the money that we gain from the community, but also the importance the community gives us. And there is a financial value for it. When you go and stand in a bank, when you go elsewhere, people treat you very differently. There is also a value which one has to recognize, which is not only monetary in every transaction. So Aravind started, this is all Dr. V's vision, with a strong value system and also a strong delivery system. I think delivery system is very important because that's where you can really reduce cost. In our case, we are a high volume organization. All our hospitals that we built today are built for anywhere, like in Chennai, we can handle 4,000 to 5,000 outpatients a day. We can perform 500 surgeries a day. But we are able to build this after 43 years of journey. If we had built this as our first hospital, by now we would have done and dusted. This wouldn't have been possible for us at all. So starting for the first 10, 15 years, you're struggling. The struggle makes you stronger so that you're able to handle things at the much later stages. So some of the challenges faced by the founder and the core team. No proven model to follow. A lot of us are struggling, right? This whole change in insurance and the pressure on pricing came in the last 20 years. Not even 20 years, 15 years. In 2005, 2007, this was not the dialogue discussions that we were having. In the last 10, 15 years, the whole discussion has changed. Please remember, I think the governments have woken up to the needs of people again. The CM scheme, PMJ scheme are all coming because 1.3 billion people are saying healthcare is a problem in my society. Not that people were not dying earlier. People were dying younger. People were not, with a certain level of economic prosperity, people are aspiring to have better health. That can't be a pain for the family. And that's what you saw in America, that's what you saw in UK. Every country went through this journey of what India is going through. So the challenges that they had was capital, manpower, working systems, technology, like all of us would go through when we are building an organization, and also sustaining the organization of financial and quality. I made this point, a small point, which is actually a very significant point. Age at which he started the organization. I think it's a very important point. Dr. V started this organization at the age of 58. So he was a coach, not a player. I think a lot of healthcare providers, the challenge is you're a player when you're building the organization. So you compete and you don't build an institution. It is always you versus the other. So somewhere great institutions are built by coaches. What I mean is, They are not people who are competing, who are not saying, oh, this is this doctor's hospital, this doctor's. You can't build great institutions like that. You have to grow beyond that individual. You have to grow beyond it. So that's something which was very essential for us when we look back, that it was not Dr. V who did everything, it was the whole team. And that's how the journey began and went on. So in our case, I would say the first 15 years was a mission-driven organization, a lot of scarcity, a lot of innovation, a lot of sacrifice. But after 1990, 1991, we become a mature organization where we are able to think more proactively. Till 1990, we can't think. It's like if you're earning 10,000 rupees a month, you can't think. Every rupee you'll have to spend. If you're earning 1 lakh, you can think. Am I going to save? Am I going to do something? So in the first 15 years, we were in that first bracket. In the second, now we are in that bracket of strategic level where we are able to think and plan. So this was phase 1, resource scarcity, capital and human resource, sacrifice and commitment, more internally focused. Again, that's another thing, right? A lot of new hospitals come and they suddenly start advertising in big way. Why? Get focused internally. Get your systems. If tomorrow, if a hospital is there, like Aravind Hospital, I say we can handle 4,000 patients. If tomorrow 4,000 people come, we will die. We don't have the capacity. We don't have the capabilities to handle. We will have to grow slowly. So how do you grow slow? Don't get panicky. That's what we have learned. There is no point because you put a large infrastructure, don't try to fill it up very quickly, because if you fill it up very quickly, you'll send bad signals. You may not be able to give good quality care. You may mess up on a few things because your staff are not mature enough. Long work hours, average compensation. Again, that's a challenge, right? I always wonder if hospitals recruit a doctor at a very high salary, it's very difficult, right? The doctor has already peaked in his career. So you bring a peak doctor into your organization, he is not going to go down. He's going to, at least he or she is trying to stay at the same level. But your costs are going sky level. For a new hospital, will the patient be willing to pay you that much? So these are all challenges that we see. And the phase 1 today has become very technology intense. You can run a hospital without doctors, but not without machines. So it's highly technology intense today. And innovation is the only way that you can match, people can't pay. And all this is possible, viable, affordable, sustainable is only if we start thinking differently, if we start thinking innovatively. What has already happened, if we start practicing, it's not going to work. Because none of the healthcare organizations in this country are in a pink of its health. As you can see, the large 4-5 hospitals, only one is with the same owner in the last 5-7 years. All the other large systems have changed hands significantly. So in our case, most of our hospitals, most of the healthcare system, the way we look at it is we always go after the existing demand. That's why I said, is there a possibility to look at the community and understand what their needs are? You talk to anybody, you talk to the joint replacement person, they will say, oh, India needs 500,000 joint replacements, they are doing 25,000 joint replacements. India needs a million heart surgeries, they are doing 250,000 heart surgeries. I'm just throwing numbers, I don't have the exact numbers. In eye care, they will say 15 million surgeries are needed, we are doing 7 million. But when you put up a hospital, you don't get patients. You don't know where these millions are hiding when you want them. But in a meeting, in a public space, we are able to articulate these big numbers. When you look at India, it's 1 billion people and you're able to articulate. Something is preventing these people to come and get care. Maybe PMJ is the what do you call, the catalyst which will change the game. But even when PMJ comes, are we ready to handle that as providers for all this big numbers? So I think a lot of times the institutions, Arvind's thinking is, how do we look at the unmet need? How do we go after the undiagnosed need? Because nobody is interested there. You go and work there, you're able to surface the need. So we do a lot of eye camps, screening camps, primary vision centers. Again, accessibility is an important element if you want to build, right? You build a large hospital in a big city. Big city is already crowded. In fact, that was a big challenge for us. Why do we come to Chennai? We came to Chennai not for Chennai. We came to Chennai because Tiruvallur, Kanjipuram, Vellore. Those are the 3 districts. Why Chennai? Doctors are sitting in Chennai. People are sitting in Chennai. Providers are sitting in Chennai. If you can harness them and if you can tap the market of these 3 districts, then you are able to provide a better eye care. So that was our logic of coming into this city. Scarce resources, again, all of us are struggling, right? At one end, we say we don't have enough doctors. We need to bring doctors from other specialities to become allopathic doctors. Somewhere there is a scarcity in that. But are we even utilizing our existing doctors well? That is the challenge. You bring more for what? We are not doing what you are supposed to do. Like, I'll give you one. So an average ophthalmologist in Aravind does about 1,500 surgery. This is not a big number. Pamal Shankara will do that. Many of the established hospitals will do this number. But when you look at the average Indian ophthalmologist performance, they will do 300 surgeries. So even the existing team can go fivefold. Between all of us, we may employ 5% of Indian ophthalmologists. 22,000 ophthalmologists, we may employ maybe 2,000 ophthalmologists, all put together. The other 20,000 people are performing at suboptimal level, at 20% of what they can perform. So how do we tap into that? How do we make that work? We also recruit young women, like most of the, I'm sure you're also doing that in many ways. Young women, train them for 2 years. Why would we do that? You know, young women, all our, 95% of our workforce, this is the first job that they do. All of the doctors come from our training, all the nurses we recruit, because we want them to come with a clean slate. We want them to see, not carry a baggage from elsewhere. Work within our cultural ecosystem and be able to establish the culture and work. So these young women, I would say, are the backbone of the organization. I'm sure all of us would say that about nurses and the nursing team. Financial viability is important, and financial viability will not come by maximizing price. Financial viability will come by productivity. Especially in this age where you don't have control of price, that's the only thing that you have control of. Culture of cost consciousness, dependence on earned income rather than donations or grants. Phase 2 in our case, leveraging scale. Once you become stronger, you have scale, right? You have multiple points of organization. Your base is stronger, you can grow much wider and bigger. So we were able to upgrade to best technology. We were able to train people in a much more sophisticated way. Our standardization of systems and process became better. And we were able to comfortably play in a competitive ecosystem. Imagine we started in Madurai, in a very small town where we didn't have competition. But it gave us 30 years of ability to experiment and refine what we need to do. So when we came to a bigger city or wherever we go, it gave us the conviction that what we are doing can sustain and will be able to leverage our strengths. And some of the things that Aravind went about, cost is not only providing care, right? We also have consumables, which is a factor. So we also went into manufacturing, also consultancy, and also research, as Dr. Mohan pointed out. These are all evolution of an organization. You start with service delivery, and then your doctors are there, then you get involved in research. Manufacturing in our case has been kind of a backward integration. Not many people will do it, but our team had the vision to do that at that point of time. So some of these pictures. So finally, this is my last but one slide. I would like to point out, if you're giving free care or affordable care, please remember that is helping your organization more than your paying patients or your patients who are paying much more. Because free gives you a tremendous community acceptance. It gives scale. You know, without scale, I mean, why would you go to a doctor? You don't go to a doctor because that doctor has done only one such procedure. You go to a doctor because that doctor has done thousands of such procedures. Scale gives competence. There is no other substitute for that. So if it's a very busy doctor, very difficult to get appointments and all that, that doctor has had scale. He has enough experience behind him. That is why you are able to go to him. So scale is very important. Efficiency. It comes, unless you have scale, why you have to be efficient? You have to have scale and then you try to manage it by being efficient. And frugality, you know, because patients can't pay. Today, in fact, a lot of times I would, with PMJ and with other insurance programs, as an organization, we were doing a vitrectomy surgery for 3,000, 4,000 rupees, trying to be, obviously we wanted to be charitable to the patient. Today, the government is giving 22,000 rupees. Why should Aravind be charitable to the government? We are happy that way. You are now paying us 5 times more than what we were collecting from the patient. So it is helpful for us. Now we can reach more people. We can serve more people is the kind of thinking that we have. And paying is also important. I'm not discounting paying. Paying gives you a financial surplus. People focus on outcome. Paying patients won't come because if you give poor outcome. They want better service quality, better product quality. and also access to technology. So let me conclude with the last slide with the quote of our founder. Intelligence and capabilities are not enough. There must be a joy of doing something beautiful. I think healthcare is a epitome of joy of doing something beautiful. People come back and really, it changes lives. Genuinely, it changes lives. It's not a flippant statement one can make. I think somewhere leveraging that will be the best way to tackle the days to come with all these changes that are happening. Thank you.